Thank you very much. So I'm a practicing electrophysiologist, so this is what I kind of take in my back pocket with me, facts about anatomy in congenital heart disease when we approach ablation or device management. So first is the normal heart position of the conduction system, and then we'll look at where this can vary. Two areas are very predictable, the sinus node and the penetrating bundle of His. One less so, the AV node. The sinus node we're going to find at the junction of the sinus venosus with the primordial atrium, sulcus terminalis, as you climb up to this angle between the SVC and the epicardial portion of the atrium. It's epicardial, it's not discrete, and it's fairly consistently located in patients and throughout adult life. The second most common predictable site for the conduction system is the penetrating bundle of His, the so-called site which an echocardiographer can pick out the conduction system better than an electrophysiologist. You find the tricuspid valve, the fusion point between the septal and the anterior leaflet, see where it's directly opposed to the non-coronary sinus. And I apologize, I can't use the pointer on both views here, but if we look here, non-coronary sinus and right sinus of Valsalva, right opposite the tricuspid fusion point, the membranous septum. So anytime we see issues with the membranous septum, specifically it's going to be the penetrating bundle of His that we'll have to see what happened to it. Now the AV node is less predictable, the compact AV node, and we approximate its location in the normal heart by drawing out this triangle of Koch. The first site is the septal leaflet of the tricuspid valve. And this is key in congenital heart disease to understand the equivalent of the septal leaflet of the tricuspid valve to predict where we are likely to find the AV node. The second is a line over the coronary sinus ostial roof. And this stays at this level of the roof regardless of the size of the coronary sinus. And the third will be on this partition, the Eustachian ridge and tendon of Todaro between the triangle region and the posterior fossa ovalis. So notice the fossa ovalis is distinct and separated from where we would find the compact AV nodal tissue. Now, if we look at this in another plane that's very useful to understand in congenital heart disease, a 4-chamber plane, we're cutting through a part of the fossa and through this part that houses the compact AV node. And this is another key structure, the atrioventricular septum. So because of the tricuspid valve septal leaflet being more apical than the mitral valve, we have a portion of the septum separated from the right atrium and left ventricle in the normal heart. And anytime this changes, the position of these two valves or issues with the atrioventricular septum, specifically we have to watch for what happened to the compact AV node. So if we look through this and we picture and fix in our minds the triangle of Koch and overlay common shunts, we can see which ones will be issues for the conduction system. Now you'll see first, and I'll point out that anything in the fossa ovalis, the secundum ASD, is pretty much leaving the critical portions of the conduction system alone. Now sinus venosus defects tend to occur very close endocardially to where we have the epicardial location of the sinus node. It's rare for it to affect the entire nodal region, but there can be issues, and this is a fairly common thing we'd watch for as progressive sinus node dysfunction in patients who had a sinus venosus defect. Now, although with secundum ASD, we don't generally worry about a missing piece of conduction system, it's important to note that the geometry of portions of the triangle of Koch, the coronary sinus, and because of the dilation of the atrium, you get this large funnel type of vestibule that can distort the anatomy of the atrium near the AV node. And since this is the site that we target for AV node reentry ablation, this change in angulation is something that can produce a challenge even in patients who are post-repair of a secondum ASD. Now, what about patch closure? So the ASD itself, the secondum ASD, is clearly discrete from the triangle of Koch, but the fast pathway input to the AV node, the anterior input to the AV node, is just anterior to the rim of a secondum ASD. So if a closure device patch is oversized, this may give very little space for that exit to occur, and we can have some unusual exits during AVNRT in this patient population. Now, the big one, of course, would be a defect that's actually going to be in the triangle of Koch region, and this would be our AV canal family of defects. So essentially, the triangle of Koch is punched out. These patients, however, are not born with AV block, so the compact AV node had to move. And as electrophysiologists manipulating in the heart, we have to have an idea of how it has moved. Now, there are many choices the compact AV node and its connection to the His bundle could have had when you have this punched out portion, but by far, in the vast majority of heart defects that have a primum type ASD, you'll see this unique posterior and ventricular movement of the compact AV node, such that the compact AV node is posterior to its usual location and much closer to the floor rather than bordered by the roof of the coronary sinus. Now, its continuation as the penetrating bundle of His, as a result, also has to move, and it stays stuck or very close to the course of the septal leaflet of the tricuspid valve. So the sacrosanct regions in patients who partial AV canal, complete AV canal, primum ASD, when we're ablating and manipulating, is the line of the septal leaflet of the tricuspid valve up to the coronary sinus ostial region. Now, what about ventricular septal defects? So notice that most of them will have nothing to do with the conduction system. So outlet, muscular, but inlet and membranous, especially a membranous VSD, as forcing a change in the course of the normal conduction system. So let's see what that is. So the first is, when we think about this membranous VSD, we think about a right side aspect and a left side aspect. What happens when we lose this is the only way the penetrating bundle of His can make it from the AV node to the interventricular septal region is it has to course posterior and leftward. So what that means is the landing zone on the crest of the interventricular septum is shifted leftward. So recording a good His bundle signal in hearts with a prior membranous VSD will be on the left side of the interventricular septum. And to get there, it takes a course posterior to the defect. So the two changes are posterior and then leftward. Now this is important because to map this, we actually would find it in a location where it would be at like the fusion point region of the aortic valve and the mitral valve. So this would be like our aortic mitral continuity region, And it's not straightforward to map this region just with prolapsing the catheter. Specific manipulation to turn and point posteriorly and leftward records the signal at this site. That's key because you can backtrack from there where the compact AV node is and avoid that region during mapping and ablation. Now switching here to another very important condition when we think about where is the conduction system, what do I need to think about differently? And that is in congenitally corrected transposition. So two main differences from the normal heart create these differences in the conduction system. The first is the relative position of the atrioventricular valves. So the intuition for the atrioventricular septum is different as a result of this change in the plane of the atrioventricular valves. The second is the centrally located pulmonary trunk. Pulmonary trunk taking the place of the centrally located aortic annulus creates a difference in the course of the penetrating bundle of His and the possible locations for the compact AV node. So putting these two together, we can come up with a couple of guidelines. First, key finding to anticipate functional and number of AV nodes in CCTGA is the size of the pulmonary trunk, the pulmonary annular size. A normal size or enlarged pulmonary valve, typically there's only one AV node and a normally located penetrating bundle. And that normally located AV node is in the mid-septal region below the plane of the pulmonary valve. So very similar to normal. On the other hand, if the pulmonary annulus is small, those patients are more likely to have two AV nodes. And the AV node that's new here is this anteriorly located AV node, kind of at a fusion point or continuity point between the pulmonary annulus and the mitral annulus. So here we have one mid-septal and one higher that we'll have to negotiate with the pulmonary annulus. Now connecting these two is a penetrating bundle, but it's more like a sling, and the plane of the sling is defined by the presence and size of a ventricular septal defect. If there isn't any, the sling is in the plane of the annulus. But as we get further and it's a larger VSD that's present, then there's separation of the sling-like penetrating bundle tissue that can produce ventricular elements in this continuity, so-called Monckeberg sling. Now notice that components of this conduction tissue will be both above and below, superior and inferior to the ventricular septal defect. Now there's usually dominance of the compact AV node. Typically in dextrocardia with CCTGA, the compact AV node that's in the mid-septal region is the dominant node, making it very challenging to do slow pathway ablation. In levocardia with CCTGA, the anterior node is the dominant node. But this can be easily determined during EP study by keeping a His recording catheter on both of these His bundles, pacing the A and seeing relative decrement and which one continues to conduct. Now the position of the sling can also be deduced electrocardiographically. If we see there's a changing pattern in the QRS, the chances are the sling is relatively more ventricular with potential exits before a common exit. On the other hand, if you record distinct His bundle recordings, but regardless of which one is conducting, the QRS looks quite similar, it's probably an annular ring and there either wasn't any or a very small ventricular septal defect. A very unique site that we typically don't consider for SVT in the normal heart, but very important in CCTGA, is the right ventricular outflow tract. Because of this centrally located pulmonary valve, the right ventricular outflow tract posterior position is a common exit, the fast pathway equivalent exit for the anterior located AV node. As a result, sometimes you'll have to target that site for mapping, and especially if you've documented that the mid node, the mid-septal node is dominant, then this can be a site for successful ablation in difficult AVNRT in this patient population. A quick word about device management in CCTGA. So this was a patient referred for a resynchronization device. So what happens to the venous system for placing a resynchronization device? We've got inversion of the ventricles. What does the venous system do? There are two important things for an implanter to be aware of. The large Thebesian vessels opening into the right atrium are the rule. Very few hearts do not have this in CCTGA, and as a result, wire manipulation or catheter manipulation can go into one of these Thebesian vessels and have to be alert to that possibility without thinking that this is an unusually located coronary sinus ostium. The second is the veins stick with the ventricle. So the left side of the body located morphological right ventricle has right ventricular veins, which are scant, small, and rarely go more than the proximal third of the ventricle. So this makes putting in a resynchronization lead via the coronary sinus challenging. It can be done, however. The key is to remember that the septal veins tend to be more like the normal heart. So the anterior interventricular vein and the middle cardiac vein are very similar to the normal heart, and it is possible to engage these to get a lead via the coronary sinus. Conduction system pacing is also possible in this patient population. Here, the only difference is there's inversion of the bundle branches, and unlike with conduction system pacing where we target the left bundle across the septum, little easier to do because it's a wider bundle. Here it's a narrower landing field that you'll have to do some mapping, screwing in the electrode to get to the right bundle for resynchronization of the systemic ventricle. Few words about conduction system in Ebstein's anomaly. So Ebstein anomaly, we know that the conduction system has got this really intimate relationship with the septal leaflet of the tricuspid valve. So the question is, if that valve does not delaminate, where is the conduction system? And the answer is it still stays with the point of attachment of the septal leaflet. So even if there is this delamination, the location of the compact AV node is very similar. It's just that since it's harder to visualize where this septal leaflet insertion point is, we sometimes might forget that we're close to the AV node during manipulation. A word also about recognizing the plane of the annulus, very, very important, because not only is the AV node located in that site, but the same plane of the annulus is where we're going to eliminate most of the accessory pathways, not at its ventricular insertion site, which could be quite a ways displaced. So identifying that, sometimes this sharp angulation near the right coronary artery, using the mitral and then going just a little bit lower to estimate it, or when the coronary sinus is seen, finding the anterior lip of the coronary sinus and just thinking or looking about 3 to 4 millimeters ventricular to that site gives a good idea of the plane of the annulus, predicting where you'll find the compact AV node and where you're likely to find in the RAO view the accessory pathways. Just a quick word about conotruncal anomalies and the conduction system without transposition. So here, it still very much follows the rule like a membranous VSD. So expect to see the primary penetrating bundle on the left side of the interventricular crest and a posterior course through the inherent septal defect, or if patch closed, posterior to that patch closure. Tetralogy of Fallot, the compact AV node location, unless there are other anomalies, are not that different, but one word to keep in mind for catheter manipulation, it's also much easier to record on the left side. Part of this is because of the septal defect. The second is this rightward tilt of the outflow septum that makes it very hard to balance the catheter and record a His bundle from the right side. Usually you can do it the same way, but with transeptal or retrograde targeting the left, and very similar, you have this like right-sided AV node, then it disappears to the left, and then comes back into the plane of view through the distal conduction system when viewed from the right side. A word also about some variations in patients with tetralogy and other conotruncal anomalies, that some remnants of the His-Purkinje in the outflow tract are sometimes seen in these patients. So-called dead-end tracts or Lancisi type fibers found up to beneath the pulmonary valve. An example of a case of a signal from a tract like this in a patient with triggered ventricular fibrillation and tetralogy of Fallot. Another word about the conduction system, remember the right bundle reaches the free wall of the right ventricle through the moderator band. The moderator band itself can be involved in some congenital anomalies. Most of them are quite rare. But anyone with right ventricular hypertrophy, severe right ventricular hypertrophy, tends to get abnormalities in thickening, fibrosis of the moderator band, and is a site that you may have to map or ablate, especially if there's a pattern of the VT exercise related with changing morphologies during the arrhythmia. Maybe a couple of minutes on atrioventricular connections and the conduction system. So here there are myriad variations to think of. The principle, though, I think is regardless of whether it's a double inlet, common inlet, number and type of a straddling valve, if we focus on the triangle of Koch, so interatrial septum, coronary sinus region, and see wherever that winds up, and map in that region, you're likely to find the compact AV node. So if we visualize this, regardless of where or the type of ventricle, small, large atrioventricular connections, we focus with imaging in the EP lab for the interatrial septum, triangle of Koch where it's meeting the coronary sinus on its roof, and a good bet that you'll be able to map the AV node or leave that site alone to avoid AV nodal injury. You saw this in the prior talk on embryology. A lot of attention now in the EP field, adult EP field as well, on this retroaortic nodal tissue, source of atrial tachycardia, junctional-like tachycardia, some variants of AV node reentry. The key in this structure to keep in mind is in transposition or unusual AV canal defects, it still seems to stay with the aorta. So even if you switch with the pulmonary trunk, the place where you'll have to map for this is the posterior sinus of the aorta. Couple of points for heterotaxy syndromes for the electrophysiologist. So here we're aware of the variations, so kind of classic teaching has become modified, but general rule still remains that if we have right atrial appendage isomerism, although not exclusive, we're more likely to find more than one primary sinus node focus, maybe a little bit more than half the time, and distinctly unusual with left atrial appendage isomerism. On the other hand, just absent or rudimentary sinus tissue or actually sinus node-like tissue firing as the primary rhythm closer to the coronary sinus, more likely maybe a quarter of patients with left appendage isomerism, very rare with right atrial appendage isomerism. So just to kind of look at the location where if there are two competing sinus nodes are seen, the first is very similar. It's epicardial, crista terminalis endocardially, and thinking epicardial close to the junction with an SVC. Regardless of whether a left SVC is present, the second or competing sinus node tends to be in the crest of tissue between the usual location of the right and left pulmonary vein ostia. Now, in heterotaxy, two AV nodes with a sling are also common. Here, the slight difference is it tends to be more posteriorly located. So it's almost like that mid-septal location is missing because we have, say, a large atrial septal defect, including a primum type defect, common atrium. The node is posterior, as you would see in a primum ASD. And then, like with CCTGA, with a small pulmonary annulus, you also get this AV node. So unlike CCTGA, the twin nodes and sling are wider separated and tend to have a wider sling into the tissue. It's also important to remember, I didn't cover this in much detail at all, but in congenital heart disease, electrophysiologists thinking about the conduction system, you also have to think about the coronary anomalies involved and learning to recognize the node to the AV nodal artery. This is actually a very useful little trick that when you don't know the anatomy well or there's nothing described about the node, you can sometimes recognize the AV nodal artery and backtrack from there to see where do you suspect the AV node is going to be located. Last point I'll make is about pacing in complete transposition. So here, usually we're called to these patients for either VT ablation or for placing a pacemaker. And one of the things here to remember is because of, as in patients who are post-mustard baffle or ascending baffle, they tend to have lead damage as you go across this. This is because of maybe some stenosis, needed some stenting, so need to avoid lead-to-lead interactions. And even though it can be a complex procedure, avoid redundant leads and try to extract when you need to place another lead in this patient population. So I'll stop there. Thank you very much for your attention.
Thank you, Sam. That was great. Open for questions.
Yes, ma'am.
Thank you very much. I am Miyazaki from Japan. I have a question about the AV node in CCTGA. In small number study, and then they showed that the dominance, it showed that anterior AV node is dominant in a D loop. No, right? And then posterior AV node is dominant in D loop.
That's correct.
Yeah, and then do you agree with that? If so, I would like to know the reason.
Yeah, so the reason I don't know, there's been some discussion about like coronary sinus development, things like that, but they're very small numbers. So personal experience is like 5 patients. The study that you're quoting that looked at all CCTGA, I believe, had 3 patients who had dextrocardia and CCTGA. But it does seem to be true. In our own experience, it does seem to be true that the mid-septally located node is more dominant. The EP point I'd like to make, though, it's very straightforward to determine it. We don't have to know from prior studies. So if we record the His, put PACs posterior versus anterior, see variable decrement, so one His pushes out, the other doesn't, and keep doing it and see which blocks first. And if this is consistent, you've defined which is the dominant AV node. And I think it's a good idea to do that in all these cases, even though the literature suggests this pattern, and I think this pattern is correct. It's straightforward to make this determination.
You don't mind to ask one more question?
Yes,
Is that okay? Then, so, and then next question is the AV node in the atrioventricular AVSD, I mean atrioventricular septum defect. Then the AV node should be a posterior side. So
Yes.
the 12-lead ECG need to be show the superior axis, right?
Well, so it's two different issues. So the position of the AV node is not directly seen in the ECG. It's the course of the penetrating bundle, the insulated portion of the right and left bundle, and then the primary exit from the bundle. That will determine the axis on the ECG. So it's not a good way to anticipate whether or not we have a posterior node by looking at the ECG. That's more a manifestation of the primary exit of the bundle branch system.
So you mean it's possible to show that the inferior axis even in a patient with ABSD?
Yes, absolutely.
All right.
Absolutely.
Thank you very much.
Any other questions for Sam?
Okay.
Thank you.